Professor Salim Abdool Karim joins us now to talk about the thinking that was applied by political strategists in Britain who directed their initial response to COVID-19 and what we should learn from that. Right, Professor, good as always to talk to you. Thank you for your time. At the start in Britain, people there, some of these political officials were talking about this concept of herd immunity. Obviously, they were wrong, and herd immunity didn't actually apply in this case.
That's correct. So when we look at these infections, we know that for any infection that is coming through our community, a certain number of people are vulnerable and will acquire that infection. But there will be a range of people who have immunity because they encountered a similar or the same virus before. So if you take, for example, influenza, every year we get influenza coming through our community. But many of us have had this particular kind of influenza several years ago, and so we have a little bit of immunity. We don't have enough to have herd immunity, which means that you don't get the spread of the virus, but we have some immunity. This particular coronavirus did not exist before November of last year. So it's only been in existence in humans, as far as we know, for about 3 to 3.5 months. That's it. So humans, the entire community, has no immunity. Everyone, rich, poor, black, white, men, women, everyone. No one has immunity. So everyone's going to get infected if they encounter the virus. The issue that they did not factor into this planning in Britain is that about 81% of the patients who get this infection get a mild form of it. But it's the 19%, it's that 1 out of 5 that will require hospitalization. And of that, about 5% of all the patients require some kind of assisted breathing and ventilation. And so that's why the shortage of ventilators. So they didn't factor that. They thought, well, why don't we just let this virus run to the community? You know, people will get it. It'll be a mild disease, a bit like flu or cold. And so it'll all be done. And then eventually enough people will have immunity that we don't need to worry about it. Well, that's a deeply flawed problem, deeply flawed thinking, because you did not factor in the situation that you're going to have 1 out of 5 people needing medical care. And so that's why you see in England the number of deaths is rapidly rising. It's just incorrect thinking.
Does this suggest then that our government's plan of mass testing, mass screening, getting as many people in through these testing kits, the mobile testing kits that have been announced as possible, does that suggest we're on the right track with doing that?
When we look at the experiences of the countries that have been successful in the way they've dealt with this particular epidemic, testing has been a key part of the strategy. Without testing, one doesn't really know where the virus is spreading. And without knowing where it is spreading, you don't really know what you're tackling. And so when you're in that kind of situation, you cannot afford to cut back on your testing. We in this country are simply not testing enough. When you think about it, that we've had 45,000 tests or so done since the first infection on the 5th of March. Our goal as a country should be around 25,000 tests a day. So the tests we've done already, we should have done that in 2 days. So what we know is that when there's this ramping up phase, it isn't that easy to do this kind of numbers of tests. But what the minister announced, or what the president announced, of going and doing the mass screening is doing exactly the correct strategy based on what we know from Korea and based on what we know from China. Screen, screen, screen. Test, test, test.
And then, I mean, the BBC's been reporting Australian scientists are working on a vaccine. I mean, vaccine is, of course, the magic word at the moment. Everyone's talking about it. You talk about the fact that this virus didn't exist in humans until November. Does that make it a lot harder? I mean, when I think of vaccines, I mean, the first one against smallpox, I think, in the UK, if I remember correctly. If you think of measles, if you think of the vaccines that so many of us are used to, so measles, mumps, rubella, these are old viruses, viruses we know a lot about. This is a new virus. That must make it harder to create a vaccine?
Yeah, so when we talk about achieving herd immunity, often we're trying to achieve herd immunity through a vaccine. So we're trying to get enough people vaccinated so they don't get the real disease. The challenge we have here is that there is no vaccine against this coronavirus, obviously, because we didn't know it existed until a few months ago. We also do not have any vaccines against any coronaviruses. So it's not like we could take another coronavirus vaccine, adjust it, and use it for this particular instance, which means we're starting basically from scratch. So there are several candidates that have been made. The most advanced of those is called an mRNA vaccine, and that's already in testing in Seattle. So we are already on the right track in terms of developing a vaccine and now to move to testing.
There's going to be a lot of testing to come. It's probably going to be quite some time before we know if all of these vaccines work. And then after that, you've got to do human testing, of course. And then only after that can you really start to roll it out to a community.
Yes, so even if we go into human trials now with a vaccine, that vaccine will only be available after this epidemic is gone. The process by which we have to determine whether a vaccine is safe and whether it's effective just takes time. There's no shortcuts to it. So anything we do, we will not likely see a vaccine anytime this year. So we cannot bank on it. But why must we be focusing on a vaccine? Is because we should be doing that to prevent the next cycle of this virus or a similar virus in the future. So we lay the foundations now with these trials.
Professor Salim